So my name is Ashley Nickerson. I've been a registered nurse for 14 years this May. 8 of those years I've been in home care. Prior to that, I worked on a telemetry floor. I worked in a skilled nursing facility, and for about 6 or 7 years, I worked in family medicine and primary care. And I currently work for Norwell NVNA and hospice. I work for the certified side, so not hospice. And I've been with Norwell, it was 2 years this month. My first COVID patient, I did not know that he had COVID. That was on March 30th. He was admitted to us for skilled nursing, physical therapy, occupational therapy. He was, I believe, 58 years old with multiple comorbidities. He had COPD, CHF. He had a renal transplant 2 years ago. So he was quite sick. And at the time we were doing COVID screenings before we would go into a patient's home. So we would ask them, we had a flow sheet that we would follow and ask them questions, if they were having new onset of cough, shortness of breath, fevers, chest pain, so I asked him all of those questions, to which he replied no. Also at that time, per the CDC recommendations, we were wearing masks to each patient's home. But at the time, it was not suggested that we wear protective goggles or eyewear. So I went into his home, to do his assessment, and found that he was actually very short of breath. He did have a new cough. He did have a fever. So I had called his physician, and we had sent him to the hospital. I want to say that was on, I think, a Tuesday. And on Thursday, when I was getting ready to go out and see patients that morning, my boss had called me to let me know that the patient had tested positive for COVID. And due to the fact that I was not wearing protective eyewear, again, it wasn't suggested at that time, that put me at a moderate to high risk for infection. So I had to go and have a COVID test. So I went to my primary care physician, and I had the COVID test, which was extremely uncomfortable. And they told me that it would be about 48 to 72 hours until I would get the result. They advised me to come home. I couldn't return to work. I needed to quarantine at home. They suggested that I stay in just one room of my house. They suggested that I only, if I had 2 bathrooms, that I use one and my family use another. They suggested that, my husband bring meals to the door and that I not go out into the kitchen, and, that if I was to leave the room, I had to put a mask on. My family had to wear a mask, and I have 3 children. My son, Braden, will be 10 in December. Riley is 9 and Olivia is 7. So that was really challenging and difficult. And, it was, nerve-wracking. And I didn't have any symptoms. I felt fine. But of course, when you go and get tested for something like this, and, you've seen people with these symptoms and seen patients that have COVID, then you kind of start to wonder, oh my goodness, do I have these symptoms, or do I have a headache, or do I feel feverish, which, I didn't. But so that was Thursday I got tested, and then I found out my result was that Saturday. So it was about 48 hours, and luckily that it was negative. The test was negative. I did not have COVID. But those 48 hours were really challenging for myself and for my family. I remember one time I had left my bedroom to go out and use our first floor bathroom, and my son was in our kitchen, and he, approached me to come over and give me a hug. And I said to him, Braden, you can't hug me right now. I haven't got the test result back yet. So, we need to try to keep our distance until the doctor calls. And he started to cry, and he said, this is so terrible. I hate this virus. I can't even hug my mom. So, that was really, really hard. And really hard for him and for me and for our whole family. But, luckily it ended up being a negative result, which, was good. And that patient ended up, he ended up doing well. He was rehospitalized a few times after being diagnosed, and it was really more related to his other comorbidities. Like I said, he had CHF and COPD and diabetes and renal failure. So that was, why he went back into the hospital. But, for everything that he had going on, he did pretty well. But, going into, once I knew he was positive, then obviously I was donning all of, our PPE to go into his house. He lived in an apartment building, a low income senior housing in Quincy. So to get dressed, to put on all of my equipment, I had to do it outside of his apartment door in the hallway. And, that was challenging at times because people would be walking by and of course they have questions or they're looking at you like they're afraid of you. And so, that part of it was hard. And it's also hard just being there by yourself, putting all this equipment on. That was really the first time, my first patient. So, donning and doffing all this equipment and not having another nurse or clinician there to check and make sure you're doing it correctly and that you have your N95 on correct and your bonnet and your face shield and your either your gown and booties and, you're in this full PPE. And so that, that was kind of hard too. I had other patients where we would have to get dressed on their back porch. It was raining and it's like, you have to get this stuff on before you go into the patient care area. So those were all challenges, and then some other challenges was just wearing all that equipment. And a lot of times, like our visits with our patients are, talking with them or actively listening. And, you've got a mask on, you've got a face shield, you've got a bonnet, you look like this kind of like, astronaut. And the patients, they can't see your facial expressions, you're, all gowned up in gloves, and it's very impersonal, and it's hard for them to, tell if you're smiling, if you're being reassuring to them. So a lot of times I felt, I would, try to minimize my exposure while being in there. You try to do what you need to do while you're in there, but I would try to leave at least a minute or two to just chat with them and explain why I'm wearing what I'm wearing, that it was to protect them and to protect me. And just try to explain each piece of PPE, just to try to make it a little bit less scary for them, and to just try to make them feel a little more comfortable in a very, tough, uncomfortable situation. I think total I had maybe 12 or 14 COVID patients. The last time I saw a COVID patient was in May. I haven't had any COVID patients since then. I did have the first COVID patient for NVNA, and I believe I had the most for my service area, which is Quincy. But certainly other areas of our service area also had COVID patients, and all the nurses faced the same challenges that I did. Just especially if we had a COVID patient maybe that needed wound care. And you're trying to minimize what you're bringing in. You don't want to bring your bag in, you're carrying in supplies, just kind of trying to, some of our patients' homes are very small, they're cluttered. There's not often a place where you could, put a bag or put your equipment. So you're kind of trying to, balance someone's leg on your shoulder while doing wound care and, making sure that you're, not exposing yourself or them. So, all of those things were challenging, but, Norwell always made sure that we had, the proper and correct PPE that we needed, that was recommended by the CDC. And even now, still every week, we fill out a PPE survey and we, let them know what we have and what we need. And so they do that in an effort, obviously, to conserve PPE and to make sure that we have plenty for when we need it. As far as anything I would change, I can't really think of anything I would change because it was just such an unprecedented time. And so I think trying to prepare for, I'm not sure you can really adequately prepare for something like this. You can have all of these standards and you can have all of these flow sheets and, kind of an idea in mind of what you would do, but oftentimes when you go into these situations, all these other things pop up that you just, and that's kind of the nature of home care. I've learned being in home care that the plan always changes. You never know what you're going to walk into, and you have to be really flexible. You can't, your schedule is going to change. You could look at your schedule at 7:00 in the morning and by 8:30 it's totally different. So I think that's kind of just the nature of home care. I think that being able to see these patients at home, was really helpful to them. I did have one patient, it was really sad, who got COVID, and he decided that he wanted to die at home. He didn't want to go into the hospital, and his reasoning was that he said, I don't want to go in there and die alone. Now, whether he would have actually died from COVID, maybe he would have, maybe he would not have. But he felt as though he didn't even want to go to the hospital for treatment. He wanted to stay home, and we supported his choice, and we were able to get him over to our hospice side of NVNA fairly quickly, and his wishes were fulfilled, and he was able to stay home. So as far as changing anything, I can't really think of anything that I would change. I mean, we also know all these things now that were more difficult, just kind of little ins and outs of putting on our PPE and, and lots of times in home care, you have 2 hands, but you feel like you need 4. You become really resourceful. I think, it's hard. Home care is kind of hard in the sense that, you're not on a floor and you can't, you can't walk out of a difficult situation in a patient's room and go to the nurse's station and say, hey, this just happened and this was really hard, or a patient passes away and you can go sit in the break room and talk about it. With home care, it can be kind of isolating sometimes because you're often the only clinician in the home. So, it's kind of puts a lot of pressure on you that, you need to, really have good skills, clinical skills and assessment skills, and have confidence in what you're seeing and have confidence in what you're reporting to the doctor. And, because oftentimes we're the only eyes that see some of these patients, or ears that are listening to them. So it definitely brought, I think, I know our team on the North team closer together, and not just the nurses, the PTs, the OTs, the social workers, the home health aides, speech, all of us definitely, we're leaning on each other, a lot. We would talk at night, we would talk through text. Lots of times we had a group text going, or we would just have conversations and just kind of vent about the day and what it was like, and, or certain PPE that didn't work, if there was some face shields that someone didn't like and they suggested using a different kind, or but also for just the emotional aspect of it, it was extremely stressful. It was, scary. And, I think that everyone felt that. And, when you go into a patient's home, you don't want them to know that you're afraid or that you're nervous. You want to kind of have that poker face. And, so it's hard doing that all day. And then you come home, and oftentimes, if your family isn't in the medical field and they don't you feel like they don't understand, and you're trying to explain it to them, it was really comforting to be able to talk to our nurses and our field staff, just to exchange stories and just kind of give each other the support that we needed. So yeah, I definitely think that we became really close, and we were anyway, but we certainly are much closer now as a result of COVID.